So in the world of pediatric cancer, we have this group called the Children's Oncology Group, and it's made up of over 200 hospitals, both here in the U.S. and internationally. And those groups are made up of scientists and clinicians, and we all come together to help design what we think are the best treatments for childhood cancer. So it's pretty unique in that if I diagnose a person here at Children's Mercy, or if another doctor diagnoses someone in let's say Washington, D.C. or in Texas, then those patients would all get treated the same way. So you don't have to travel far to get the best treatment, because we are all working together to make those plans for those children.
Leukemia is the most common form of cancer among children and teens, accounting for 1/3 of all cases. 3/4 of pediatric leukemia cases are acute lymphocytic leukemia, or ALL, and the majority of the rest are acute myelogenous leukemia, AML. ALL is most common in early childhood, peaking between 2 and 4 years old, and AML is slightly more common during the first 2 years of life and in the teenage years. Leukemia was first discovered in ancient Egypt around 3000 BC, although it was not called leukemia. They simply called it thick blood, and at this time it was deemed incurable. The word leukemia comes from Latin as a combination of leuc, which means white, and amia, which means blood. So the word leukemia means whitening of blood. The term leukemia was first introduced by Rudolf Virchow in 1847. In the 1700s, doctors started treating leukemia with arsenic. Patients during this time were diagnosed based on physical symptoms such as pale skin, swollen lymph nodes, and an enlarged liver and/or spleen. Research in the 1840s led to the discovery that leukemia patients experienced changes in the color and consistency of their blood. They also determined that with leukemia, there was a maturation of white blood cells. So doctors began running blood tests to determine if a patient had leukemia or not. In 1850, Dr. Henry Fuller treated the first documented case of childhood leukemia, a 9-year-old girl at St. George's Hospital in London. The first bone marrow examination technique to diagnose leukemia was discovered in 1879 by F. Mosler, allowing more accurate diagnosis of leukemia.
So for each diagnosis, it's different. Because the treatments are different based on what type of cancer they have. But once we diagnose a patient, then we usually will revert to a standard protocol if one is available, and then if not, we get the chance to sort of design them ourselves and decide which drugs have worked in the past for this type of cancer, if there are some, and then put together a group of drugs that we think would work to best treat the patient.
In the early 1920s, radiation therapy was discovered and quickly became the premium treatment for leukemia. In the beginning of radiation therapy, the dosage was determined by when the patient's arm would turn pink, almost like a sunburn, and was called the erythema dose. During clinical trials in the 1940s, American scientists found that soldiers who had been hit with German mustard gas had lower white blood cell counts. They discovered that this was caused by nitrogen mustard and it could be used to kill cancer cells. Chemotherapy treatment was born. The first bone marrow transplant was performed in 1957, but unfortunately had poor results. It would later be fully developed in the late 1970s with the use of tissue matching. In 1958, Dr. Sidney Farber found that aminopterin, a compound related to the vitamin folic acid, produced remissions in childhood leukemia by blocking the chemical reaction needed for DNA replication. Aminopterin was eventually replaced by methotrexate, the current standard for chemotherapy. The drug vinblastine was discovered in 1961 and was approved by the FDA to block a key protein in cancer cell division, providing another option for chemotherapy. In the 1960s, cytarabine was found to provide a major boost to other chemotherapy drugs. 1993 brought about another surgical discovery, the first stem cell transplant. Today, leukemia is diagnosed through blood tests that determine the number of white versus red blood cells and very immature white blood cells called blasts. If there are too many white blood cells and not enough red blood cells, or there are too many blasts, the patient is determined to have leukemia. Doctors also perform bone marrow biopsies in which they take a sample of bone marrow from the back of the hip bones. A lumbar puncture, also known as a spinal tap, will also be performed to look for cancer cells within the cerebrospinal fluid. If leukemia has already been diagnosed, at this point the doctor will inject chemotherapy drugs into the cerebrospinal fluid to prevent the leukemia from spreading to the spinal cord and brain.
we will give the cancer treatments, and then we reevaluate usually after a cycle or two, depending on what type of cancer they have. And what that is, we kind of go back to like either imaging or bone marrow procedures to decide if the cancer is going away based on the treatments we've given or not. And if it hasn't, then sometimes we have other protocols we could follow for what we would call refractory disease. But a lot of times it's proceeding on to another type of treatment. So something like a bone marrow transplant or immunotherapy. So maybe some of the newer therapies that really haven't been tried in those type of cancers before. Because once the disease is refractory, it's a little bit harder to treat. And we try to give the best known treatments up front. So we're not holding off until something happens to give the best therapy. We're giving that from the get-go, from diagnosis.
The doctor may also perform a series of chromosome tests. Normal cells have 23 chromosomes, but some types of leukemia change chromosomes. For example, two can swap DNA so that part of one attaches to a different chromosome. Or there may simply be too many or too few chromosomes within a cell. Both are signs of leukemia. After the patient has undergone treatment, a process called cytogenetics is used to determine how effective the treatment was. Over the course of 2 to 3 weeks, leukemia cells are grown in a lab dish, and the doctors look for changes in the chromosomes. Fluorescent in situ hybridization, or FISH, is also used to determine treatment effectiveness. In this test, pieces of DNA from bone marrow that only attach to certain parts of chromosomes are linked to fluorescent dyes so that doctors can determine if there have been chromosomal changes. This is used more often than cytogenetics because it only takes a few days to get results, instead of 2 to 3 weeks. Polymerase chain reaction, or PCR, is used to look for very small numbers of leukemia cells or minimal residual disease during and after treatment.
Every day there's a chance that something new will come out and something better will be available. And I think they could remain hopeful that there are over 200 institutions of clinicians and scientists that are completely dedicated to curing childhood cancer. It's all we talk about, it's all we think about, it's all we work on, and everybody's giving their all every day to try and find a cure for these kids. So if there was hope, I would rest my hope in that, knowing that you can sit and rest assured and take care of your kid as a parent, as a mother, as a father, and know that there are millions of brains elsewhere that are working on the little things that we need to help get your child to a cure.
The current standard for how well a treatment does is the 5-year survival rate, which is the percent of patients who live at least 5 years after they are first diagnosed. Today, the 5-year survival rate for ALL is more than 85% overall, and the 5-year survival rate for AML is 60 to 70%.
If you know someone who's willing to donate to a good cause, then pediatric cancer research would be great, and even right here at Children's Mercy, because we do not get a lot of, childhood cancer is rare, and of all the funding that goes to the American Cancer Society and all of these big name places, we get less than 4% of that funding. So all of us who are doing the research are really working hard and doing this with our own money and grants that we're applying for, but it's not money that's coming from the bigger places that people donate to. So if you could use this and someone wanted to know what they could do, then I would say donate to your local children's hospital for pediatric cancer research.